Welcome to the I Spy with My MyOI podcast. I am your host, Brittany Sierra. I am a certified orofacial myologist, registered dental hygienist, and lifelong learner. My goal with this podcast is to expand your knowledge of orofacial myofunctional disorders and to bring you up to date in current literature so that together we can get to the root of the problem. You ask, we'll answer by collaborating with true pioneers in specialties associated with the myo world. Join me on this journey as we dive into the life-altering world of tethered oral tissues and airway space. Let's do this thing. Quick disclaimer, all content expressed on this podcast are the views and opinions of the speakers and is for informational purposes only. You should not rely on this information as a substitute for, nor does it replace, professional medical advice, diagnosis, or treatment. Because every person is so unique, you should always consult with your specialized healthcare professional. Joy Moeller is a dental hygienist, formerly an associate professor at Indiana University, who has worked as a myofunctional therapist for many years and currently has a private practice in Pacific, Palisades, and Beverly Hills. Myofunctional therapy has now been proven to be effective in reducing AHI numbers by 50% in adults and 62% in children, as well as lower oxygen saturation. Snoring and sleepiness outcomes improve. Joy is founding lecturer with the Academy of Orofacial Myofunctional Therapy. Joy wrote a chapter in Sleep Medicine Clinics, a chapter in Sleep Disorders in Pediatric Dentistry, published in 2019, and a children's book on tongue position, as well as many published studies and other chapters in textbooks. She is currently on the board of the American Academy of Physiologic Medicine and Dentistry, a multi-disciplinary medical and dental group interested in airway problems, where she received a Lifetime Achievement Award March of 2015. Joy has lectured worldwide and was invited to speak at grand rounds at the Mayo Clinic in Rochester, Minnesota, and to Stanford's Sleep Residency Program. She currently teaches with the Palo Alto School of Sleep Medicine and taught with UCLA Dental Sleep Postgraduate Program, as well as a guest speaker at USC Dental Hygiene Program. Everybody, please welcome Joy Moeller. All right, awesome. So let's just get started with, I remember you are the reason why I became a myofunctional therapist. I don't remember learning about it in my hygiene program. I went to the Forsyth School of Dental Hygiene in Boston, and it was 5 years into being a hygienist, reading one of my RDH magazines, that I came across your article and your name, and I was like, what is this? And then I looked it up and learned more about you, and I was like, oh my God, I need to know more. And then I Googled, and your course was in New York, which I'm right in Connecticut. So I was like, okay, definitely have to do this. So let's just talk about how, you became a myofunctional therapist.
Okay. Well, I think it was probably more of a family affair.
Okay.
Because everyone in my family had issues with this. I personally had 2 upper bicuspids and a lower canine extracted when I was 7 for serial extraction from being a mouth breather, and allergies and things my whole life. And then I had jaw surgery, and everything went wrong when I grew up. And so, from personal experience. But then my son had a problem, my youngest son. He was colicky as a baby. He was born a breech. He turned in the canal and was born screaming. For 1 year, he slept only 20 minutes. So severe colic and ADHD went into, we had his tonsils out, adenoids. He developed headaches and severe sleep problems. And back then, he would have been diagnosed as autistic, I'm sure. But at that time, they didn't have that diagnosis. So I kept taking him from doctor to doctor and doctor and doctor, kind of like all of our patients.
Yeah.
And finally, I wound up in the neurologist's office, and they felt exploratory brain procedure would be indicated. At the time, I was a hygienist. working in a very progressive dental office where the dentist had taken a course in myofunctional therapy. And he said, before you do any brain surgery, let me take a look at him. So he looked at him and he said, his tongue is in the wrong place. So I said, what? I'd never heard of that before. And so we did some exercises. He wanted him to see an osteopathic physician as well. And then he made a little bite thing for his mouth. So within 3 weeks, his headaches were gone. His stomach ache stopped. He started eating 2 meals at a time. And 3 months later, his teeth started straightening out. He had a very high, narrow palate that just completely changed. I witnessed this and I went, oh my gosh, I need to learn this. So I went back to school. At the time, there was one program in Florida with Dan Garliner, which was a 2-week program, a week of learning, and then a week of kind of like an internship following one of the doctors around. And I came back and I was like gung-ho to do this. And what I found was a lot of doors slammed in my face. A lot of people were, what, I've never heard of that. And, you know, and I just sort of learned to keep my mouth shut. I worked in a few orthodontic practices. At first, I was working in the dental office where the dentist had helped my son, but then I soon learned that it was better to align myself with more of a neutral position, either my own office or I worked in a perio office. When he wasn't there, I worked in ortho practices, pediatric dentist, and an ENT and a chiropractor's office, and I would move from office to office. I also worked at Children's Hospital in the speech department for a while.
Oh, okay.
They're myofunctional therapists because they didn't know anything about it other than help their speech patient. So, and then I moved to LA about 20 years ago because my boys lived up here. And I started my own practice. And so that was really different because there were so many people that needed this, and you know, nobody in LA was doing it.
I remember, you know, when I took your course and just sitting there, like in the first couple hours, being like all these patients were like coming to my head and family members, and it was just like, holy cow, this just all makes so much sense.
Yeah, definitely. Well, and then I said my other people in my family, my husband had TMD really bad. And he had been to all kinds of dentists, physicians, ENTs, you know, nobody could help him. Mm-hmm. It seemed like he even had 3 teeth extracted because he was sure that would help the pain. He had serious, like tic douloureux, they called it, which is trigeminal neuralgia. And eventually we split up because he became a drug addict from all the medications he was on. So that part. And then my other son, Mark, who some of you may know, he kind of isolated from the family issues and he became a bookworm. He just read everything he could and was considered a genius by his teachers. And he kind of isolated, and then now he's real involved because he's the managing director of our AOMT Teaching Academy.
Yeah, so let's talk some about that. So, you know, the AOMT Academy of Orofacial Myofunctional Therapy. Let's talk about how you kind of got started with it. You know, what's new. I know that you guys have a new book that you are releasing, I think pretty soon. I pre-ordered it. I'm super excited for it to come in.
Yeah, it's really an amazing book. But, well, about 30 years ago, you know, I really wanted to give back. And I started teaching classes in Europe with Barbara Green, who's another myofunctional therapist. She had been doing it a long time. like myself. And so we started teaching classes primarily over there. And then we were both members of the IAOM, and we were teaching courses for certification through them. And then I guess then we called ourselves the AOMT probably in the 1990s.
Okay.
And then after a while, the IOM was very, very adamant about everything being evidence-based, and they didn't like some of the outside the box stuff that we were doing. So we broke away because we were more interested in the field of sleep medicine. And then Barbara stepped down, and my daughter-in-law, Samantha Weaver, is co-teaching with me now.
Oh, how awesome.
Amazing. And her background is speech. And my son took over as a managing director of our academy. So we call it the AOMT, Academy of Orofacial Myofunctional Therapy.
That must be so exciting to have a speech pathologist kind of, on board with you, because it's always nice to kind of get our DH and a speech pathologist take on everything. I have a lot of people that come to me that ask, well, what's the difference between speech pathology and myofunctional therapy? So if you want to talk a little bit more about that.
Oh, sure. Well, I think the field of dental hygiene, as we know, focuses on the mouth and prevention. And speech pathology focuses on the mouth and speech disorders. But there are other people that I feel should be taught myofunctional therapy too, and that's occupational therapy, because they deal with function of the body. And physical therapists, of course, physical therapists deal with muscles.
Right.
So I think those four professions, and then any allied health field, needs to learn about myofunctional therapy, like nurse practitioners definitely should. Physicians, anybody in the field of sleep medicine should as well.
Yeah, I mean, it's definitely, a collaborative approach on all ends. I always have patients also, they come in, they get sent to me, say, from their orthodontist because of their tongue thrust. And, the orthodontist points it out to them, and then they come in and I'm like, we're starting to go through the medical history and everything. And I suggest they see an ENT, or I suggest a sleep study, or whatever I suggest. And they kind of look at me like, well, I thought I was here for you to work on my swallow. Like, why are you telling me all this other stuff? So let's talk more about the whole, sleep component, airway component, and just how important it is.
Yeah, it seems like that initial appointment that you have with patients becomes an educational appointment where you have to really I have a lot of pictures, I have studies in my operatory, I have a lot of videos of my patients, I have before and after pictures. I have to explain everything about how it started and how our skulls are getting smaller, and how it isn't just a tongue thrust, it's tongue rest position, and how it affects your airway. And I have lots of pictures that I show and go into why it's so important, not just for your teeth, but for your posture and for your digestion and for your sleep disorders, breathing, chewing, and it's encompassing almost every aspect of healthcare. I talk about how the tongue is attached to a bone in your neck called the hyoid bone, and it's actually the rudder for the spine. So if it's not in the right place, everything else in your body gets off. And then you have to go into, of course, restricted oral tissues to make sure that, they understand that this may be part of their treatment plan.
Right. So now let me ask you a question. How do you go about, we're telling them that, we see a tethered oral tissue, lingual frenum, and then they say, well, my pediatrician never pointed that out to me. How would you respond back to that?
Yeah, nobody ever told me about this sooner. Why didn't anybody? That's what I get every day in my practice.
Oh, yeah.
And I just talk about the new research and about how 40 years ago when I started in this field, I might have seen 1 or 2 persons a year that had a tongue tie. And now, according to the latest research out of Brazil, and I always show them that study that shows that approximately 34% of all infants born now have a posterior tongue tie, not even just an anterior. So I say it's a combination of processed foods that we're eating, the skulls are getting smaller, people aren't chewing, you have baby food, you have, a lack of breastfeeding. And I say everything's morphing. The tissues stay the same, but the structure gets smaller. So that therefore there's extra tissue. And I say this is just a little bit of leftover baby tissue. I call it to try to calm them down. And I say the procedure for correcting this is very, very simple. It's non-invasive.
Yeah, and just how much it'll improve their quality of life. I just recently had 2 women in their 60s actually have their frenums released. One of them actually did like a video testimonial for me that's on my YouTube channel, but she just could not believe, she said even just from leaving the office, getting in her car, reversing out of the parking lot, like how much more range of motion she had in her neck. Like she couldn't believe it. So it's always interesting to hear patient stories afterwards. And then there's all, I always tell patients, reference them to different videos they can go to. There's some that they can even watch the procedure now, which is really awesome. There's so much more, as clinical research being done. So it's also amazing.
Yeah, I hear those stories every day, and it's so inspiring for me, and it really motivates you to keep going in this field.
Absolutely, 100%. I want to just go back to one thing, because you were talking about, with babies and chewing and all of that. I remember in your course, one of the slides you put up there, it was your grandson, and he had I think it was a chicken wing in his hand, or a chicken bone or something. So if you want to talk more about how important chewing is, that would be awesome. I remember looking at that like, oh my God, I don't even remember how old he was in the picture. I want to say
7 months.
I was going to say 6 months. Okay, so 7 months, which is amazing.
Well, about maybe 6 or 7 years ago, I went over to London to speak at Dr. John Mew's course. And it was like a 3-day symposium. And I was always interested in feeding and dental facial development because I think a lot of hygienists have a good background in nutrition and how I did nutritional counseling and all that, which is so critical to all of it. So when I was at Dr. Mew's conference, I heard Jill Rapley, who was a public health nurse, talk about baby-led weaning, her book that she came out with. And she talked about how babies do not need baby food, that they need to start chewing at a very early age to develop the arches. And that's one of the reasons why I think there's so many more people that have tethered oral tissues, because not only the pesticides and all that's in our food, but also the fact that this baby food, before 1935, there were no blenders. So baby, as soon as they would pick up something and put it in their mouth, it was food, and they would chew on things like you saw my grandson chewing on his chicken leg. But it's true, when infants are given baby food, they think that's normal, to just, here comes the airplane with the spoon. And so they never learn the proprioception of their tongue to move the food in between the molars on one side and then the other. So therefore, they just swallow it down and their tongue doesn't have to work. We have 14 to 16 muscles inside our tongue, and a lot of them have not been activated by eating processed food. So we need, and part of myofunctional therapy is to isolate, activate all these tongue muscles, get them to move the food around and develop that sense of chewing. Is this food smooth enough to swallow? And that the brain needs to be involved in determining if it is smooth. And that's what happens to little babies that are given adult food. As soon as they can sit up, as soon as they have that eye-hand coordination to pick up something real small to put it in their mouth, they're ready for people food. And, I always tell patients, you want to get the book and read it. It talks about starting with like a piece of cantaloupe or an avocado or something.
Now, is this the baby-led weaning book that you were talking about?
Yeah, it's a great book. There's actually a follow-up to it that has recipes for babies.
Oh, well, that's awesome.
Yeah, so baby-led weaning. And if you go on YouTube, you'll see tons of videos like my grandson where babies are eating different things. The only thing you have to be careful with baby-led weaning is that you don't start it at 12 or 13 or 14 months. It's too late then, because the child is used to baby food, and if you just introduce all kinds of hard food, they just think they have to swallow it down and they'll choke.
Right.
So it has to be done as soon as they can sit up, and no baby food, because my feeling is baby food is processed junk food for infants, and it doesn't allow the jaws to grow.
Yeah, and like you said, I mean, back in the day, there was no such thing. So why do we need it now?
Yeah.
I mean, people did perfectly fine without it back in the day. So
basically, Gerber and beech nut, lots of money.
Yeah, that's true. That's very true.
And it's convenience food.
Right. Okay, so how about, let's talk about, what are your thoughts on early orthodontic intervention? What age are you making sure to send your patients to, or recommending that they have their first orthodontic evaluation?
Well, I think Kevin Boyd in Chicago is the true leader in this field. He's a pediatric dentist and an anthropologist. And he feels that it should start the third trimester of pregnancy, that mothers need to be educated on airway, the importance of airway. And most mothers now are waiting and having children later. And so they've gained all this weight and they're, they can't sleep on their back. They're sleeping on their side. And so they're blocking their airway. And a lot more babies are born premature now. And 80.6% of infants, according to one study, that are born premature are born with sleep apnea. So the baby comes out with a high narrow palate. And what's the first thing they do in the NICU is put a pacifier in. Yeah, so that even reinforces the high narrow palate. Right. So we have to really start with education, with educating pregnant women and physicians and nurses, lactation consultants, all of those people that deal with babies or pregnancy. I know right now I have a patient whose mother is a neonatal specialist. She had no idea all this. Every time she comes, she's like a sponge. Tell me more. What are the new studies? It's like fascinating how physicians are not being taught this.
Right.
It's so critical. So we just have to keep educating. I think that's the number one
for sure
thing that myofunctional therapists need to do is educate. their patients, educate the doctors of their patients, the parents of their patients, the grandparents of their patients, all of them. So it starts with that. And research. The more research we have, there are a few doctors that are helping us with lots of new studies coming out every day. And that's very exciting for me, because for years I would run into roadblocks where the doctors would say, show me your research. And I would bring out one or two little studies, this isn't any good. It's a category, a poor category 1. It's not even that. Look at this and this and this problem. So I think really anybody doing myofunctional therapy should have a little bit of a background in science, how they can read science, how they can interpret science, and know the difference between a really good study, because we need that. We have them now. We have good studies.
I'm constantly printing things out, giving them to people. I'm like, here, every time I recommend, again, if somebody's like, oh, how come my orthodontist didn't say that, or my pediatrician, I send them all the articles that I possibly can. I'm like, it's here. It's not just coming from my mouth.
Good. It's going to change. And I know the book that Licha was involved in, our new book, the Myofunctional, will help, because there's tons of science in there.
Oh yeah, I'm so excited to get started on
that. Yeah, it's a very good book. Be sure to read the prelude to it. It's very good.
Oh, I will. I plan on reading from cover to cover.
Good.
Okay, so that we talked a little bit about the early orthodontic intervention. What about your thoughts on palatal expansion and the different types of palatal expansion?
My thoughts are the best palatal expander is tongue, believe it or not. If the tongue is starting to function, at an early age, that can help. However, sometimes we need a little help from science, and there are many different, there's over 30 different palatal expanders out there. And I think any pediatric dentist that's really into airway is going to start, 2, 3, 4 years old, doing something if that palate is real high and narrow. Myofunctional therapy is definitely indicated. We can use things like the myomunchie, and now we have the new froggy mouth, which is amazing to get the back of the tongue up.
Oh, tell me a little bit about that. I don't think I knew about that.
Well, it was invented by an orthodontist in France who felt that it's like little lips that go over your lips, little like rubber lips, and it keeps the mouth open. So when the person swallows, they have to isolate and activate the genioglossus muscle to swallow. Because the tip of the tongue is not going to do it. There's no stop point.
Right.
Kind of a real cool thing. And it gets the brain involved in knowing that there's a different way to swallow. There's a lot of new inventions coming along the pike, I mean, it's like unlimited. There's over 30 different appliances for expansion. But again, you've got to get the breathing under control. It's difficult to get the tongue up when the palate is covered with different plastic materials, right, as it expands. But you can work on lip seal, you can work on posture. So work around that appliance and then with the appliance. And you can isolate and activate the tongue muscles so that when you finally reach that 38, 40 millimeter from molar to molar width, the tongue is ready to go up there, and then it's like a
has its home, nice and ready for it.
Yeah. But I definitely think it's going to be earlier and earlier. I think 3 years old is going to be, because according to Maria Piavia's study and Karen Bonnock's study, if you don't treat that airway issue between the age of 3 to 5, by the time they're 7, they have learning disabilities and behavior issues. So, tonsil problems, it just keeps exasperating.
Spiraling. Yeah, absolutely. Okay, so you just actually brought me to my next point, tonsils and adenoids, making referrals, to the ENT to have those assessed. What are, I guess, not only your thoughts on that, but how you handle it when they come back and say, they look fine, or we're just going to watch them for now. And that this child is suffering, that they can't breathe, they're not sleeping. What are your thoughts on all of that? How would you handle that kind of situation?
Well, generally, I would give them some of the research that's out there on it. But also, I would tell the parent to get another opinion. Definitely. And these are the reasons why, the brain is not going to develop properly, and that the child will be sick all the time. And, it's a blockage in there.
Right.
A lot of times parents will find that they find a doctor and they get this, they don't need it. And the parents are like, relieved. My child does not need this surgery, see? And I'm happy they don't need it. And they try a lot of holistic techniques to shrink the tonsils, like take away dairy and put them on, nasal washing, and do other things. Even in my area here, they're doing ozonated water, gargling with ozone and all that. Laser treatment on tonsils. That's all fine and dandy, but I don't know. This is my child, and somebody told me that their brain cells were not developing. I would do anything to get that airway open.
100%. And I think, like you said, the more that, you bring awareness to the parent of how much it's affecting them, not just that, they're sick all the time and they're missing school, but how it's affecting, like you said, their brain cells and their activity, their ability to concentrate and perform behaviorally, academically, even athletically, if we're going to, talk about, breathing and all of that.
Yeah, definitely. And, their new study was out showing that if your tongue is working and resting in the roof of your mouth, every muscle in your body works better. Yeah. So that's really good for sports-minded people. I find that I try to find out what's important to that family or to that patient and try to zero in on that. And then also how to motivate the physicians. I say the best way is to, put it in writing that child is having airway issues, have the parent, listen to the child sleeping and record it and bring that recording with. Also bring some of the research out. I know the study that was published in the New England Journal of Medicine talking about how in 6 months, after waiting for or after removing the tonsils, how things improved so much. So, and the patient's total health, ability to breathe correctly.
And what about the importance of myofunctional therapy even after the tonsils and adenoids come out? Like, I've gotten from some ENTs that have taken the tonsils and adenoids out, telling the parents that, everything will just kind of work itself out now. They're going to start breathing through their nose. Everything's going to be okay now that we, physically removed that blockage.
Again, Maria Pia's study showing that if you don't do anything after a tonsillectomy, the sleep disorder comes back within a year, 6 months to a year. So, because you haven't really looked at the cause of the problem.
Right.
Just the results.
Okay. And, as we're talking about, I think we might be freezing here a little bit.
Oh.
Give me 1 second. Okay. Sorry. My little computer thing was spinning. But we were talking about breathing and all of this. Now you are a Buteyko practitioner, correct?
Correct.
Okay, so let's talk a little bit about Buteyko breathing. I know, actually, I just looked up one of the courses you guys are offering, again in New York, which is locally to me, well, local enough because I can drive or take the train. In July, you have a breathing course. I think it's like the part 2 of the Intro to Myofunctional Therapy.
Yeah.
And, it's talking a lot about the Buteyko.
Yes, I want to be sure to let your people know that just taking one course and studying some of the research is not enough to really be 100% great practitioner. That's why we added a series of courses. We have a course on freedoms, we have a course on breathing, we have a course on TMJ and posture and sleep apnea. And it isn't just me teaching. We have physicians, we have dentists, we have physical therapists, we have occupational therapists, lactation people. I mean, there's just, we probably have 10, 15 different people teaching with us. It's a total of 120 hours now. So it's pretty comprehensive. And I think we're the only organization that does that many courses in that much depth with that many other teachers, not just one or two teachers.
Yeah, I'm definitely going to look into that. I've been, looking more into becoming a Buteyko practitioner myself. I definitely, do a lot of breathing exercises with my patients. I always say I feel like we're always kind of going to be students in some way because there's just always something to learn. There's always new research coming out, and
absolutely
anything that we can do to help our patients, because again, that's why we do what we do, anything we can do to help them and improve their quality of life. If you want to talk a little bit more about, what Buteyko breathing is, where it came from.
Sure. Started in Russia, probably 50 years ago, not sure the exact time, but Konstantin Buteyko was an MD, and he noticed that people were, right before they died, they were gasping for breath, and they were like breathing through their mouth heavily. And so he tried to figure out why they were doing that and what he could do to change that. And the whole thing is the brain. Buteyko breathing is all about programming the brain, because normally, and this is how I explain it to patients, it's when the child reaches 2 or 3 years old and goes to nursery school. Maybe the child's been totally healthy until then, and they go to nursery school and they are around all these sick kids, and they come home with a cold and sore throat. And so what does mommy do? Makes hot chicken soup and takes them to the doctor, gets them the right medicine, makes them stay home and, lay down and, rest until they get better. And so then they get better, the infection's gone, but they go back to school, but their brain is now thinking their mouth is their nose, because it's easier to breathe through the mouth. You just open and you got an open funnel there. You don't have to worry about clogged noses. You don't have to worry about struggle. But when you're sick, your brain definitely goes to the emergency vessel, which is the mouth, to breathe. And so, because children are young and their brains are what the brains are, they continue mouth breathing. And so what Konstantin Buteyko said, we need to trick the brain into realizing that your mouth is for talking and eating, and your nose is for breathing. So you do that repetitively, where you have the child like either hold their breath or, block their nose and move their head. And then when they have to breathe, they breathe through their nose. And if you do that repetitively long enough, pretty soon the brain kicks in and knows that the only way we can breathe is through our nose. So a lot of people don't realize that when they talk, they stop and take a breath in, like gasp. And so a lot of it is other times, talking, you have to slow it down. I have them read a paragraph, and then when they have to breathe, they have to, only way they can breathe is through their nose. So they have to stop at the end of the sentence, take a small breath in and out, and then keep reading rather than. So it's just looking at what they do on a daily basis and how they breathe, even in exercise. That's the hardest part, is to retrain nasal breathing during exercise. But you can.
I'm working with a patient right now, and she's big into spinning. And she's like, I'm trying so hard to breathe through my nose. She's like, it's on my mind. It's on my mind all the time. Now every time she walks her dog, daily, and she'll text me and like, I did it. I made sure I was only breathing through my nose. And it definitely, like you said, it's a big adjustment, especially I feel like through when you're exercising.
We have some help nowadays though with coronavirus. People really can't breathe through their mouth. They really need to breathe through their nose because their nose has little hairs that protect, keep the dust and dirt, allergens and everything out of the lungs. It's really important now more than ever to breathe through your nose.
For sure. 100%. Everything that's going on right now, everything's getting canceled and it's crazy. Mm-hmm. But like you said, breathe through your nose. One thing you can do to help yourself. Is there any last words you want to leave the listeners with? Anything about any upcoming events with the AOMT or any?
The thing to do is to look at the website, aomtinfo.org. I know we're having a course in Dallas and another one in LA, and we have some local. We canceled some of our European, and we were supposed to go to Singapore. That was canceled, and Korea was canceled, and we're just kind of trying to stay close to home, and do more online kind of things.
Yep. Mm-hmm. All right, awesome. Well, we'll definitely
just look at the AOMT website and get the book. You can order the book on that website. And I know Mark's waiting for the first 100 books to come in, which are already sold. So
yeah, I pre-ordered mine. I feel like it was like 3 weeks ago or something. So I hope I'm in that first 100. I'm very excited to get that. Well, I thank you so much, Joy, for coming on here and being you're our first guest. I was so excited to get you on here because, again, you're the reason I became a myofunctional therapist. So thank you.
Okay. Welcome.
Yeah, this is an honor to have you on. So I appreciate it. Okay. And yeah, everybody go out and check out the AOMT, and you can find out some information on there. You guys have books on there, research articles. So even if you're not in the medical dental profession, I know you have some other resources on there for patients, educational tools as well. So again, thank you so much.
Thank you so much for having me.
Yeah, absolutely.
Okay.
All right. You take care, Joy.
Okay. Bye.